We present a case of post-LASIK traumatic epithelial ingrowth in the center of the cornea of a 44-year-old male. The patient underwent LASIK surgery 2 years before the trauma. He had an accidental penetrating trauma in the center of the cornea with a Japanese knife. The knife penetrated through the flap and part of the stromal bed. He complained of decreased visual acuity, photophobia, and persistent discomfort. The patient was referred to Adasa Medical Center 2 months later. This is the affected right eye. You can clearly see the significant opacity in the stroma in the pupillary zone, which affects the visual acuity. At presentation, his uncorrected visual acuity in the right eye was 624 and improved to 612 by pinhole. And in this picture, we can see that the opacity is due to epithelial cell ingrowth under the flap through a cut in the center of the cornea. There is also underlying stromal haze. The corneal topography presents a typical appearance of central epithelial ingrowth with irregularity in the center of the cornea and oblique astigmatism of about 3 diopters. The mechanism for the unusual location of the ingrowth is the migration of the epithelial cells through the traumatic flap injury. We present a surgical approach in which the flap is partially lifted for ingrowth removal using Dr. Joseph Frucht Perry's technique. The procedure requires lifting the flap, scraping the epithelial ingrowth, and replacing the flap to its original position. The possible drawbacks of removal of central ingrowth in this case are ingrowth through the periphery of the flap, recurrent ingrowth through the corneal central cut, deep lamellar keratopathy due to prolonged exposure of the stromal bed and intensive scraping of the inner part of the flap and stromal bed, and misalignment of the flap. To minimize the exposure area of the stromal bed, we lift only the part of the flap necessary to remove the ingrowth. We begin by placing the first limiting stitch through the flap and the stroma. The cornea is marked to allow a precise flap replacement at the end of the surgery. With a blunt spatula, the epithelium at the border of the LASIK wound is broken. A second limiting stitch is placed, creating the new hinge site. After lifting the flap, the ingrowth is exposed on the flap side and easily removed within less than 30 seconds. And now we can see the location of the cut on the stromal bed side. The flap is then replaced and tightly sutured with 10 all-nylon stitches along the marks. All the stitches are done without the use of forceps to grasp the flap or the corneal tissue. This is done to prevent misalignment of the flap, which may cause postoperative ingrowth through the periphery of the flap. The 2 limiting stitches are then removed. In order to prevent the regrowth of the epithelium under the flap through the corneal central cut, we devitalize the central epithelial cells over the cut. It is done by placing a sponge soaked with 20% alcohol for 30 seconds, followed by washout of the alcohol. Finally, a bandaged contact lens is placed. This is the cornea 2 weeks later, just before all stitches were removed. There is still haze in the center of the cornea. 9 months after surgery, the patient is asymptomatic. His uncorrected visual acuity is 6.9 and best corrected visual acuity 7.5. There is localized mild haze, which is hardly seen by the slit lamp examination. There was no recurrence of the ingrowth. The topography presents still some corneal irregularities. However, the central 3 mm are without significant astigmatism. Only 0.4 diopters of astigmatism compared to 3 diopters of astigmatism before the treatment, as you can see in the left topography. Central post-traumatic epithelial ingrowth may be safely and efficiently treated using the presented surgical approach. Thank you for your attention.